question. Everyone is okay, pneumovax, older patient, chronic patients, important. What position do you put your patient who has pneumonia? Is upright position, semifluorous, breathing problem. And how do you assess the lung sound? What is the best position for your patient for listening the lung sound? Sitting up is a good sign. When they're sitting, you can hear their lung sounds are. All right. All right, so pneumonia, how do you diagnose pneumonia? How do we diagnose pneumonia? X-ray, very good. How do we diagnose TB?
Sputum.
Sputum, yes, the sputum. X-ray you do it, but you don't confirm the diagnosis until you do the sputum. Any X-ray can show patient looks like they have TB because they're showing the shadow. But how do you know someone has TB? By sputum exam. Pneumonia, because it shows the shadow, it shows consolidation, and it shows what side of the lobe is affected and what kind of pneumonia they have. What is a bad pneumonia for nurses to be for your patient are? What kind of bad pneumonia if you have? Aspiration pneumonia. If your X-ray come back and patient has aspiration pneumonia, that doesn't look good. What does it mean? Patient aspirated, especially your 2-feeder patient who has it, who's laying in a bed. We are not elevating the head. So what happened? They aspirate. Aspiration pneumonia is not very good as a part of nursing care. So we can prevent pneumonia by turning, deep breathing exercise. Laying your patient in bed is not good. So some of your question, I said upright position is good, listening lungs is good, X-ray, antibiotic you will give them, CPT, bronchodilator, all that you can go. Oxygenation, patient would need. Now we will move on to the next thing. You have thoracotomy, surgery. And a lot of time when your patient has done surgery, they have is pneumothorax word. Collapse of the lung. What is pneumothorax? Collapse of the lung. And when your patient has collapse of the lung, maybe fluid is there, maybe air is there, they have to put what? It's a surgery. Underline the word in the first line, surgical incision into the chest wall. Where do you inject that tubing? Underline the word pleural space. And this is the part we take the fluid also when we are saying thoracynthesis. I haven't talked about the procedure. So when I will talk about thoracynthesis, where do we inject the needle? In the pleural space. Where do we put the tubing? In pleural space. And what do you monitor patient? They come back breathing, respiration, and what are you monitoring in the last 2 lines? Chest tube. Chest tube is draining not all the time fluid, but maybe for air. So on your patient with chest tube, you have 3 pictures here, underneath 3 bottles. And the first bottle you have for fluid. It says fluid bottle, which is attached to the patient. Second bottle is called water seal bottle. The third one is the pressure bottle or for the patient with the suction. That's a suction which is creating. What is normal in the first bottle? The patient is having, the fluid is collecting, coming out from the lungs. What is in the normal is in water seal bottle. What is normal here? No bubbling, but what is normal? Fluctuation. What is the meaning? Fluctuation, the water is going up and down is normal. If they give you water seal bottle has fluctuation, that's normal. Water seal bottle has bubbling. So write down the word where it says second bottle, just add the word fluctuation is normal. What is the meaning? Fluctuation, the water is going up and down. If they give you a question, there is no fluctuation. What do you do now? Check for the leakage. First thing, check for the tubing. Make sure your tubings are correct. And number two, fluctuation means you may not need the bottle anymore. But what do you do when the fluctuations stop? It's time to remove the tube. But before that, check for kink, number one. And then before you remove, we have to do the X-ray, just to be seeing that the lungs are okay. So second bottle, you guys have for water seal drainage. Water seal drainage means fluctuation is normal. When they're saying bubbling, that's not normal. Continuous bubbling means leakage. And what do you do? Notify. So write down the word bubbling. Bubbling is not good in the second bottle. The third bottle, you have pressure bottle. What is normal in the pressure bottle is some bubbling is okay. But in the third bottle, if they're saying fluctuation, that is means they are not correct, their leakage is there. So you guys have to know some of the wording. Fluctuation word and pneumothorax is collapse, patient has tubing, and what do you remove from those tubing? Not all the time is the fluid, maybe to drain air or maybe to drain fluid. Now let's go underneath. If chest drainage stop, X-ray should be done. Check for kink and tidling, bubbling, no leakage from the water seal drainage. If there is a bubbling in the last bottle. If chest tube patient pulls out from the chest, what do? You cover it, but not with gauze. What do you use it? Underline occlusive dressing or Vaseline gauze. What is occlusive dressing? Air cannot go in. You don't want air to go in. Occlusive dressing, airtight. So that's what you do it, and apply the pressure immediately. If the chest tubing disconnected from suction, then what do you do? In the last line, then you container of your fluid with sterile saline and you put the tubing in the sterile saline. So if your tube disconnected from the whole apparatus, then you put them in the water seal drainage or maybe a saline but sterile. So everyone, a little bit to know your patient who come back from chest tube drainage, the tube comes out, what do? If fluctuation is not there, check for kink, do the X-ray, time to remove the thing. If there is too much of bubbling, that means there's leakage. Now I will move on a little bit, is oxygen question. When we give oxygen, underline the word oxygen flow meter in the first line, humidifier. When do we use humidifier? When you are giving nasal oxygen. And why do you give humidifier? Because oxygen dries up the nose and you want to prevent them from dryness. So why do we use humidifier? To prevent dryness. Next page, if you will move on, is you know how to give the oxygen. But let's see, when you're giving oxygen through the nasal cannula, how much oxygen do you get it? On page 41, right on the top, you have 44%. So, if we have a question and you are going to give 100%, can you give oxygen by nasal cannula? No. Patient is only getting how much? 44%. Even you are giving 6%. So question for nasal cannula oxygen, you can only give when patient needs 2 to 3 liter less oxygen, like COPD patient. But when you need more oxygen, how do we go for? So number one, nasal oxygen, you let it go through the water, check if they're working okay, and you use the mask. Second one, if you go in that little box you have on 45, you don't need to read everything, but very important, I already said, humidifier question. 41, you have simple mask. When you are giving simple mask on the second paragraph, is you're giving simple mask, but how much oxygen you are still getting? 40 to 60%. So simple mass, regular mass, still you're not getting 100%. Partial rebreather mass you're getting is what? 90%. Which is more you're getting more than 90%, your non-rebreather mass. So when your questions are, patient has pulmonary embolism, patient has burn, what oxygen are you going to give? Non-rebreather mass. Why? Because that mass gives more oxygen. So everyone is okay on oxygen question? That's why I have it here. Number 3 on the bottom, pulse oximetry. What is pulse oximetry? You are checking the oxygen saturation and keep it more than 95%. You can check on the fingers, the toes, and the earlobes. And make sure you're putting on the good extremity. Any side they are weaker, you do not use that side. Now, tracheostomy tube. I will go on tracheostomy tube. You have a patient who has tracheostomy tube. How do you clean the tracheostomy tube? Which tube do we clean? Which tube do we clean? There are 2 cannula, outer cannula and inner cannula. What cannula can you remove in tracheostomy? Only inner cannula. So make sure outer cannula, we do not touch that cannula. Inner cannula, when you remove, you have on the first line, clean with hydrogen peroxide. Why? Because when you remove it, it's full of sputum, very thick. Even you wash it with normal saline, it's not going to go away. So what do? You take it out, you rinse it with normal saline, put it in hydrogen peroxide, and it cleans. A lot of questions are also for your Foley catheter. You have Foley catheter, dried mucus is there, doesn't clean. How do you clean? Hydrogen peroxide. So wherever you have a sticky body fluid, because it cleans quickly, you can clean them. When I'm going to talk for the babies, for the cleft lip palate babies and cleft lip baby, you can also clean their lip area by hydrogen peroxide. Is a good, but using a strong hydrogen peroxide on the skin, we always use half and half mixed with water. But cleaning a tracheostomy tube is okay to do with hydrogen peroxide, the strong, and maybe you can use the 100% hydrogen. So how do we clean the tracheostomy tube? Number 1, hydrogen peroxide. Number 2, replacing. When you are taking out the outer part or when you are cleaning the tie, second line. So what is in the outer cannula tie down with the tie, right? So if you have a question, you are going to remove the tie. What do? Remove the old tie, then you put the, before you are removing old tie, what do? Put the new tie. Or you have someone to help you. So what do? Put a new tie before you remove the old. Why? Because if patient coughs, the whole tube will come out. What do you keep in the room? What do you keep in the room? Is tracheostomy tube and obturator. What is obturator? It's more like a metal forceps. And why? If the tube comes out, what do we need to do? Keep it open. Otherwise, what happens? Patient, it will close and patient won't be able to breathe. So what do you keep in the room? Obturator. And what do you keep? Tracheostomy tube. What size of tracheostomy tube do we keep it? Same size. No bigger, no smaller. Because we don't change the size. And always have same size, same kind of tracheostomy tube available in patient's room. Now that's very important to have on tracheostomy question. And in suctioning, I will be talking separately, so I'm not going, so we won't waste time here in the system because I'm going to cover a lot of procedure. And in tracheostomy, suctioning, collection of specimen, I'll be talking. But here, remember, you have a patient who has tracheostomy, cleaning inner cannula, and when you are changing your tie, put the new tie before you remove old one. And keep the, at the bedside, obturator. What is bronchoscopy? Patient is going for test, bronchoscopy. And what do you do before patient is going for bronchoscopy? NPO, to prevent aspiration. And a patient has denture, remove that. But when patient come back after the test, what do you monitor? You all know gag reflex. What is second thing I want you to add is bleeding, because they have put the scope and the word is called perforation. And any question, patient is having breathing problem, maybe they're bleeding. Maybe patient has hypotension, maybe patient is bleeding. So what are two things we all remember here? Gag reflex and perforation. Two words are here. So now I will move a little bit on sensory section. Sensory is eye care for your comatose patient. You have patient, you are cleaning their eyes, and make sure your patient who's comatose doesn't mean putting eye drops. What is cleaning their eyes are from inside out. And when you're washing your patient's bed bath question, whenever you're starting your bed bath, where do we start first? From the face. And when you're cleaning your patient, remember, when you're cleaning their face and the eye, change the washcloth or change the side of the washcloth. You can rewrap and turn inside out or go and change the side. So eye care patient are, you have comatose patient because their eyes need to have a special care. It doesn't mean the eye drops. They're talking about cleaning of your patient, keeping them clean. Putting eye drops is a separate order. Hemianopsia patient means is blindness. Usually you will see in stroke patient. When patient is going for a scan, you remind them to turn. That's the meaning, because they don't see. Hemianopsia goes word in stroke patient. They're blind on half of the side. Myopia word is for nearsighted. Presbyopia is older age vision problem. And also, I will go on cataract. Cataract is very common in older population, and cataract is what is called opacity of the lens. The lens is getting bad and they can see. Underline the word aging, and also milky area of the eye can be also for cataract. Vision problem. Person start feeling the vision problem. Surgery would be done. And what would be surgery is done? They have removed the lens. And what would you be looking on the third line is late sign is cloudy pupil and may lead to blindness, but post-op care. Patient come back after the cataract, what do you monitor your patient is teach how to use the glasses, shade, and also what is very important in the second line, eye shield. What do we need to use for cataract patient? Eye shield. That's number 2 line. And the bottom second line, if you go eye shield. And eye shield should be worn when? At the night time to prevent injury. And what do you tell the patient here? Lifting is restricted. 15 pounds, more than 5 pounds I would say would be restricted, over 15 pounds none, bending, coughing, and monitoring for eye pressure. Patient complains pain in the eye, you need to notify. Constipation also is not good. Glycoma patients are high risk for diabetic patient. Pressure, IOP, we did yesterday, more than 22 is causing glycoma. And what would be in the glycoma can lead to vision, halos around the eyes. Closed angle glycoma you have, and how do you monitor glycoma pressure? On the next page, on 43, right on the top, you have tonometer. What medication do we put it in? Myotics. And we did some of the drugs yesterday for your glycoma medication. Next is for Meniere disease. Where is the Meniere disease is? Otitis media is the middle ear. And I will be talking otitis media in the peds. But I'm talking about the Meniere disease. Meniere disease is inside the ear, inner ear. And what is high in the ear is, you highlight the word endolymph fluid. So there is a fluid in the ear. It builds up a lot of fluid. And what does it lead to the patient here is balance problem. And what does patient feel here? Hearing loss in the second line. And they can lead to fluctuating hearing loss. Even they do surgery, they still have a problem for listening with Meniere disease. What are the main signs of Meniere disease is vertigo. Vertigo means is dizziness. And number 2, nausea and vomiting is very common. So vertigo, dizziness, tinnitus, and add their nausea and vomiting. And what do you monitor patient here with Meniere disease? What would you do if they give you a question, patient has Meniere disease? Number 1, they have vertigo, dizziness. So what do you do here? First thing, bed rest. So write down there, bed rest. Why? Because risk of fall. So bed rest, call light in reach, tell the patient to answer the call light, call for help, don't get up themselves. And what do you cut down? Because it's too much of fluid. Anytime we have fluid, remember the salt and water. What medication they can give them? Diuretics. Diuretics they can give them, and salt and water you restrict them. So Meniere disease is too much of fluid in the ear, which is building up and leading to hearing problem. Now I will move on integumentary system. What is integumentary is the skin assessment. How do you assess your patient if they have a skin problem? How do we assess for integumentary? What do you assess in your integumentary system for your patient? What do we assess? What are the things you are going to monitor for your patient on skin?
Color.
Temperature, yes. What else?
Color.
What are the main things are important for skin? Hydration, very good. Hydration, whatever you guys said, good. But which patient, very important for us to assess integumentary? Diabetic. What about admission? You are admitting a patient. What is very important? You do have to do assessment. What is very important here? Your skin. Every day you go to work in the morning, your LVN, charge, your patient has bruise. Are we going to assess that? Yes. What about rashes? Yes, all kind of rashes. Yes, that goes into integumentary system. What is the bruises are? Signal of what? Very good. Abuse. Bruising are abuse. And that is why we are very much, any patient has a bruise, what do you need to fill it out? Incident report. And why? Because we got to screen them. What about your patient you're admitting? Right away, skin assessment. Patient came from other facility, patient has big bruising, big skin problem. You don't assess on admission, who's going to be responsible for your patient? Us. So remember, skin is very important when you guys are working, and skin is for your bruising question, patient. Now what happens when your patient is going out on pass? Patient is going out for dialysis. For example, I'll give you, patient is gone home, in nursing home on pass for 2 days. Can they go on pass? Do we all know, can they go out on pass? Yes. Okay, so if your patient, you are a child nurse, and asking question, your patient wants to go home for 2 days on a pass. What do we do as a nurse? Number one, you have to have a doctor's order, and you give them medication, you give them all the instruction, but are you going to assess their skin before they're leaving? Yes. What happened, patient was gone home for 2 days, and now patient came back after 3rd day, and patient has bruises, and you haven't even looked at it. And after 4th day, patient is complaining pain, and you find out the patient had a fracture, and all the back is bruised up. Now family, anybody is going to take that responsibility. They will say, no, we left my mom with you, and I've not seen it. Are you going to be responsible for your patient when they're leaving to assess? Yes. When they're coming back? Yes. Even they're going for dialysis. What do you do, patient who goes for dialysis, even 4 hours? You got to document my patient is leaving for dialysis, mental status, vital sign, and your little bit assessment. If you haven't seen any bruising and you didn't document it. I had patient who goes out on dialysis and patient had fall during dialysis time. Patient came back, has a bandages which they have bruised or maybe open area. Anywhere can happen, anything. And so what does it mean here is who is responsible? And we are living in a world that everybody wants to blame others. And how do you protect yourself? Assess, document, and write it down. I'll give you one simple example. When I was a LVN many years ago, I was transferring a patient to the hospital. And during transfer, the patient had a skin tear. And when we were transferring, I got the dressing. I put it on the dressing on the patient's hand. Transportation came. They picked him up and taken her to the hospital. Patient goes to the hospital, stays there for 3 weeks, 4 weeks, and what happened here? Nobody changed this dressing, and what happened here formed the cellulitis and bad infection. Who was blamed? Nursing home? No. They said, well, the patient came with this. Yes, patient came with this, but how long a patient was there? For 3 weeks. Nobody has changed the dressing. Nobody has assessed it. And I was very good to document, and I wrote it down while we were transferring a patient, and I did call the doctor. I documented in the nurse's note. So when we had this problem as legality, when they looked at it in the chart and they talked to me, and I said, yes, I remember very well, the patient did get skin tear, and I documented and I called the doctor. So what does it say here? Your own assessment. Otherwise, who was to be blamed? Us. So remember, I'm telling you, I give you this little example, is not only we learn a skin, it's a very simple thing, but skin assessment is very important. When you're sending anybody out, anything happens, document. What happened, the condition when you have sent this patient out to the hospital? I had a patient who had a bed sore, a stage 2, was in the hospital for 4 weeks. Now the wound went stage 4, stage 3, much deeper, more bad infection, and patient was in a lot of medication. This time I'm the director. And I had a problem. Family was upset, and family said, well, you guys have sent my brother to the hospital, he had a stage 4. I said, no, he did not have a stage 4. I can show you the day he went out to the hospital. And I had a chart, I opened it, and I talked to the family members. I showed them the last documentation. So what is it important here is your assessment. All of a sudden you send a patient, make sure you close your chart with proper documentation. Assessing every day, not only in the admission. What is a skin assessment? Daily. Every shift we are doing assessment. Patients, any CNA comes and tell you, you have a redness. Now don't tell her to go put on A&D and she'll be okay. We need to go get up and see what is wrong with the patient. What can you prevent this patient? So integumentary is very important for number 1, for your assessment and for your patients. How do you assess on the skin? What else you're assessing? Rashes, you're assessing skin breakdown, bruising, any petechia you have. Maybe somebody said medication can lead to, yes. What about pruritus work? What is pruritus? Itching. Patient is having itching work. What do you do here? In your integumentary question, patient has pruritus. What do you do to prevent pruritus? What is pruritus? Itching. What do you do first thing? What does itching can cause here? Itching cause what? Infection. Number 1. I will talk about eczema. I want you to add there, eczema question. Child has eczema. Anybody has eczema, what are you preventing here? Infection. Itching is causing what? When you're scratching, the skin is going deeper, is getting infected. What does the patient is going to get here? Infection. So pruritus question, I want you to remember the word cut the nails for your patient. And what restraint in the children you can go? Elbow restraint. So remember, question can be not only skin, maybe on eczema question, maybe on a skin breakdown, maybe on itching question. So everyone, pruritus word and cutting nails, medication. Now I want you to go on the word is on that, is some of the, on your integumentary what you have is on the burn. Burn is 3 stages of burn. On number 1 in the burn is, what are the complications of the burn? We said yesterday, hypovolemic shock, infection. What isolation do we put the patient here in burn patient? Reverse isolation. Number 1, stage 1, emergent stage. What is in emergent stage? Is in the beginning, 48 to 72 hours. What is it happening here? The shifting of the fluid and hypovolemic shock. Next page, you will move on. And intravascular to interstitial. Very important, we all know shock. But what is happening in shock? The fluid is shifting in the first few hours, and that's intravascular to interstitial. Second stage is beginning of the diuresis. Now patient is taking out the fluid. What do you monitor patient here? Fluid loss, because now they're going to lose more fluid. Second stage is complication of beginning diuresis and wound closure. The wound is closing, and what are you monitoring with the wound is infection. Stage 3 is rehabilitation stage. And rehabilitation means is closure. What is the meaning of rehabilitation time is you want the patient to go as much as they can do normal. Any rehabilitation. So burn question, airway we talked about it, positioning we talked about it, preventing from infection. First degree burn is more painful, more superficial. Second degree burn, if you highlight that, epidermis and dermis is going more deeper. And that is going epidermis and dermis, and still painful. Third degree burn is going deeper, but pain is less. So what is important on third degree burn as it is deeper? On second line, I want you to highlight the word regeneration. Skin cannot regenerate. What is the meaning here? That it's so deep that new tissues are not going to come. So what is the problem? As the burn goes deeper, healing of the wound is deeper. And the problem is here, regeneration. What is regeneration? Healthy tissues are not going to come, and it will take a longer time wound to heal. Third degree burn, less pain. Now, we will go on priority, ABC, we talked about that, airway, and we will avoid the word flexion. I said that, extension is good. Hypovolemic, on your page number 45, where you have priority for burn patients is your airway. And prevent flexion. Shock is important. Second line, fluid shifting. You must have Foley catheter to monitor INO. Hydration is important. And third line, tetanus shot. Any open wound, any burn, risk for tetanus, check for if they had a tetanus shot. Next line, cradle. What is a cradle? It's like a tent. It goes over the bed. Patient is laying inside the cradle. The purpose of cradle is to bring the top linen over that, so it's not touching to their body. Cradle is good when you can use it to protect the weight of the linen. Now for burn patient is important. What isolation do we put them in? Reverse isolation. What are the complications are? Hypovolemia, decreasing fluid. Underline the word ulcer, curling ulcer. In the stomach, they get ulcer. and also duodenal ulcer. You give them hydrotherapy. What is hydrotherapy means is putting them in the water. And what is the water does it to remove all the dead tissues. And what is another way we do is the treatment for removing the dead skin. The last line, wet to dry dressing. Any question? Why do we do wet to dry dressing? We are using normal saline, and what are we removing here are the dead tissues. So we'll stop here, we finish, but I want you guys to do your questions. So